I think it's recorded.
Yeah, it is. Hi, everyone. Welcome to week 10. You're almost done. Almost there. Yeah, it's a good week. It's pretty straightforward as well. So I'm doing the intro to pharmacokinetics this week. Later on next sem, you'll have proper pharmacokinetics, which is very hard, but this week is pretty easy. Everything's pretty straightforward. So yeah, let's get started. You are going into week 10, aren't you? Don't make a mistake.
It's week 10, pretty sure.
Yeah. Because we're going into week 11 though. No, we're going into week 10. Beautiful. Let's get started. So this is just a very high yield concept that I've kind of used in the last pharmacology lecture we've done, in which faculty kind of are dividing our learning of pharmacology into these two essential phases, which is pharmacodynamic phase, which is what the drug does to the body. But today we're going to be focusing on the pharmacokinetic phase, which is what the body does to the drug. And the way you're going to remember this is through this ADME mnemonic, which is absorption, distribution, metabolism, and excretion. So the body's going to absorb the drug, it's then going to distribute it to particular compartments in the body. It's going to have therapeutical effects then it's going to be metabolized, often through the liver, and after it's metabolized, it'll be excreted. And there are certain properties that affect pharmacokinetics that include the shape and size of the molecule or drug, the charge, whether the drug is ionization, and its lipid solubility, which we'll discuss in a bit more detail. Let's go. So these are the routes that drugs can be administered. It's kind of get the big picture of this. The most high yield thing for you to understand about this is oral route is always preferred because it's the most convenient and essentially it's the easiest way for people to take drugs. Topical often isn't going to go into the systemic circulation, but that's less high yield. Most of the other ones are going to eventually get into the systemic circulation, but if you put it on topical, sometimes it can just be subcutaneous. So yeah, just get a general idea. Yeah, you can put it in lots of places. This is a very nice diagram that also illustrates different routes the drugs can be administered. And often it's going to be processed until it eventually reaches the systemic circulation. Because in the systemic circulation, it can be taken all over the body and have systemic effects and act on a variety of organs. I'll explain this liver metabolism in a second, but all you need to really understand from this is you're having a drug administered. It's going to go to a certain area related to the administration. So intramuscular is going to go to the muscle, oral is going to go to the gut, and eventually you're going to want it to get into the plasma so it can circulate all over the body and go to all these different organs to have an effect. Eventually it's going to be eliminated through urine, feces, and sweat. Yellow, yeah. So who cares about routes? This is a core concept that you need to understand here is oral route is usually preferred for convenience. There's sometimes this may be modified. Unconscious patients can't swallow tablets, so you can't give them oral route. People who are vomiting often can't absorb the drug, so sometimes the oral route isn't appropriate. Another reason why an oral route sometimes isn't considered is drugs may be inactivated through first pass metabolism. So what is first pass metabolism? When you get a drug and it goes through your gut, often it's going to go to your liver and it's made more polar there so it can be excreted. So it's metabolized to be deactivated often. So a lot of your drug is going to be deactivated when it goes through your gut. It's going to be deactivated by the liver so it can be taken to the kidneys to be excreted out. So sometimes you can give a concentration of a drug and too much of the drug is made kind of redundant before it reaches the systemic circulation and has an effect. So to combat this, sometimes sublingual drugs are given, which go direct to systemic. Sublingual is under the tongue. Nitrates are given sublingually. Transdermal over the skin. Rectal to less of an extent, really, as an alternative. And if you want to really maximize the concentration at a site, you'll give it topical drugs. So if you've hurt something over here, you're going to give the drug over there. Just rub it in. So that That way, it also minimizes adverse effects, because often adverse effects happen when drugs have sensitivity for other receptors around the body that aren't the target for what is injured. And so if you don't give it systemically, it's going to minimize adverse effects. But if you have a systemic problem, then you're going to need to do it systemically. Next slide, please. So what properties determine how well a drug will be absorbed and distributed? First is a pharmaceutical form. So if it's a tablet, it might be done in like this little capsule, and the capsule can dissolve in the gut, for example. The drug might disperse really rapidly. It might not disperse so rapidly. Main concepts for you to understand are lipid solubility and water solubility. If a drug is too lipophilic, which means it's too nonpolar essentially, it will be insoluble in aqueous cytoplasm, which means it's poorly absorbed. In other words, in areas of water, the drug won't really be able to be carried across and be poorly absorbed, and it won't be able to interact with the receptor and have its effect. If it's the easier concept to understand, if a drug is too hydrophilic, it can't cross the cell membrane because of lipid tails, and obviously then it can't be absorbed into the cell to have an effect. Ionization, if a drug has a charge, that means the drug is polar, a cell membrane is nonpolar, polar and nonpolar won't interact. So the molecules are less likely to cross the membrane if they are charged. So the key concept will be come back to, and often they'll accumulate. So if electrolytes are ionized, they'll just accumulate in a compartment instead of having an effect. And also the molecular shape and size. So as you remember from really early on, cells 1, cells 2 lectures, small molecules will diffuse across the lipid membrane more rapidly than large molecules. Next slide, please. There's kind of different ways a drug can cross a membrane. One is just through normal diffusion through a lipid. So for example, CO2 is just going to diffuse across. And often this is passive. This is almost always passive, and it's dependent on a concentration gradient. Usually the drug is lipid soluble, relatively small, and unionized. Alternatively, there can be an aqueous channel in which drugs can just, or substances or molecules can just pass through the channels. These are often passive as well. Other times you can have a carrier-mediated transport. Sometimes this is active. This is different to channel because it's more stereospecific. So a drug is going to have to, or a molecule is going to have to bind to a particular active site, and then that's going to induce a change. Sorry, one back, please. That's going to induce a change, which is going to let it enter the cell, whereas through a channel, it's just going to passively diffuse through. So the carrier can be active as well. Ionization, drugs are often in an equilibrium between ionized and unionized forms, and the environment they are in affects the proportion of drugs that are ionized as opposed to unionized. So you might remember from chemistry, you have weak acids and weak bases, and that's kind of there's a proportion that are the reactant and a proportion that are the product. And in the same way, a proportion of a drug will be in an ionized state and a proportion will be unionized. Important to remember, in the ionized state, it's polar, which reduces lipid solubility. Non-polar, it's more difficult for it to go across the cell membrane. Next slide, please. So just to continue about that ionization concept, drugs can either be weak acids or weak bases. There's a list over here. Mostly for interest, it's not super high yield. Ionized has a charge, poor lipid solubility. The fact I've said it like 8 times means it's important, but hopefully you've encountered that before. Unionized is a neutral charge, it's non-polar, so it has a good solubility. And the environment determines how much is ionized or unionized. And there's a value called the pKa constant, which indicates the pH where a drug is 50% ionized, 50% unionized. And this pKa value, you can see over here, each drug has a different pKa value, a pH in which 50% is ionized, 50% is unionized. The core concept from this slide you need to understand: weak acids in an acidic environment are unionized, and they can diffuse across cell membrane easier. They can be more effective. A weak base in an alkalotic environment, unionized. So 2 ways to think about that. One, I can't actually see the last picture here because my thing is over, but I imagine there's an H+ over here. If you're in an acidic environment, you're going to have lots of H+. It's going to move the equation to the left, and you're going to have it in this unionized form. Whereas if you're in a basic environment, the cell is going to favor the forward reaction, producing this H plus and this neutral B drug. A way I remember it, this might be too much for right now, but I don't know if you see, there's a drug called lignocaine, and it's in a few Adam Sandler movies, and that is an anesthetic, and it is a basic drug. But if you have inflammation, you have an acidic environment, and lignocaine is less effective because it's a basic drug. The acid in the inflammation makes it ionized, and so it doesn't diffuse across, and it's less effective. And just through that piece of information, I always remember weak acid is ionized in an acidic environment, a weak base is unionized in an alkalytic environment. Next slide. Thank you. There's something called ion trapping. So as I've already mentioned about 8 times now, ions are polar or hydrophilic. Therefore, they are prevented from crossing the plasma membrane. And so weak electrolytes can actually be trapped in compartments of the body if they are ionized. So that means they can't diffuse in or out, they're just stuck in that compartment. And the pH level determines the state of the electrolyte, whether it's ionized or unionized. So you can see here, you have, I can't see the diagram, but if you have a weak base in a very acidic environment, we've got another invigilator joining us. If you have a weak base in a very acidic environment, it's going to be trapped in that gastric area. Whereas if you have a weak acid in an acidic environment, it's not going to be trapped. Lots of it's going to diffuse across. And the opposite is true as well. Next slide, please. This is bioavailability in first-pass metabolism. I've been through this a bit before. This is an important concept that's been in exams, just the definition of bioavailability. Bioavailability is a proportion of drug that reaches the systemic circulation intact or unchanged. So why would a drug be unchanged or not intact? It's essentially because of this thing called first-pass metabolism that we've talked about before. And first-pass metabolism often occurs by the liver. It's when drugs absorbed by the GR tract, often carried by the portal system to the liver. The portal system is just a venous drainage. It's just drained to the liver. So the drug is absorbed, goes into the blood vessel, it's taken to the liver, and then the liver either will metabolize some of the drug before it reaches systemic circulation. Sometimes it will activate the drug. More often, it's going to inactivate it, and the drug will often be made polar so it can be excreted by the kidneys or just converted to bile. And yeah, I've written here that the CIP enzymes are here. So sometimes they can activate and sometimes they can inactivate, but often they're responsible for making the drug more polar and as an effect, less effective. The reason why oral drugs have a bioavailability of less than 100%, if you remember, bioavailability is a proportion that reaches systemic circulation intact. That's an important definition. One reason is incomplete absorption across the gut. So if a drug is too hydrophilic, it will not be absorbed easily. Too hydrophobic will not be absorbed easily. We mentioned this before. If it's too hydrophilic, won't be able to cross the cell membrane. If it's too hydrophobic, it's going to be insoluble in an aqueous environment, so it won't be effective. And another more nuanced reason is because of reverse transporters that may be able to pump the drug out. You might remember this from micro. These channels called P-glycoproteins. And one of the reasons why you'll see grapefruit contraindicated for a lot of medications is because it inhibits P-glycoproteins, which means the concentration of the drug is going to be incredibly significant. I'm just going to see what Andrew said first pass. Get absorbed. Yeah, that's a good definition. Let's keep going. If you have any questions, chuck them in the chat. Rate of absorption. This is probably the hardest concept from this lecture. It's not too bad though. So the rate of absorption essentially can be classified in 2 different categories. You have zero order or first order.
And have you?
High yield to remember, zero order is ethanol, it's alcohol. That'll be probably in a question. And so in zero order, the rate of absorption or elimination is independent from the amount of drug in the gut. In other words, gastric emptying is completely controlled by the drug itself or its formulation. An example of zero order is over here. You can see that the drug is in no way, it's actually not over there. I don't have a picture of it, but I'll get a picture of it in a second, but zero order is when the drug is in no way proportional to the concentration of the drugs that's there. The elimination is constant. It's completely based on the drug itself or the enzymes in the body that get rid of the drug. So that means often you're going to go to toxic amounts because you don't have this nice plateauing of an exponential proportional relationship. So it's the same effect as if the enzymes were saturated in a proportional relationship. You can see how, because the enzymes are saturated, it's just going to flow through. It's not going to be metabolized. So it's just going to build up and build up and build up. It's not going to be able to be excreted because the enzymes that are excreting it are saturated. Does that make sense? I think it was clearer the second time. The enzymes that are metabolizing and secreting it are saturated. Therefore, it's just going to build up. And this is a therapeutic range. When the drug is safe to use, it's just going to go over that because it doesn't have this proportional relationship. Whereas with a first order drug, it's proportional to the gastrointestinal concentration. You can see for these different doses given, it's going to reach a steady state that is pretty well controlled, as it is proportional to the enzymes used. So if you have a lot of drug, you have a lot of metabolism, so the drug concentration is going to be taken down, as opposed to here, the enzymes are saturated, so it's just going to rise up. Does that make sense? I hope that makes sense. Yeah, because if you have a certain amount of enzymes and you're adding more drug, the more drug you add, the more enzymes that are activated, the more it's going to metabolize the drug, so that drug's not going to be as concentrated. So that's why these are slowly plateauing, because all of the drug is saturated by the enzymes. Whereas here, the enzymes, you have more drug than you have enzymes. So the enzymes can't metabolize the drug, and it's just going to skyrocket in terms of concentration. Yeah, that was better. And the rate is determined by a lot of things: site, drug, formulation. Basically, everything influences the way a drug kind of course interacts with the enzyme. Yeah, sometimes it's important to delay absorption. You'll get this in a lecture in a few weeks. That's why you give adrenaline with local anesthetics. You want constriction so the anesthetic doesn't go systemically and cause lots of adverse effects and is not as concentrated. Yeah. Next slide, please. I hope that makes sense. It's the hardest thing of this week, of my lectures. Metabolism just makes a lipid soluble drug more water soluble, so it can be excreted by the kidneys. Otherwise, it's going to be in your body forever, and your kidneys need to excrete something that's water soluble. It's carried out by a variety of enzymes, CYP enzymes mainly, and most biotransformations are catalyzed by liver enzymes. And as enzymes saturate, the plasma concentration plateaus, as we saw in the first order in the slide before. For zero order metabolism, for example, alcohol, there is no fixed life, and a fixed amount of drug is removed per unit time, regardless of the plasma concentration. Whereas for first order, it's a variable amount of drug removed per unit time, as it is proportional to plasma concentration. It's another way to think about it. Next slide. We've done this one. Done this one. Beautiful. This is just an example of the effect of a rate of absorption. Please go back one, please. Back two now, please. Yeah. So here I've got forward one, please. Here I've got a diagram, which is, it's essentially the same drug is given, but it has different rates of absorption. So a fast rate of absorption, as you'll see here, will allow drug A will reach a maximum concentration in a shorter period of time than drug C, even though both these drugs have the same average blood concentration. But just by changing the rate of absorption, A is going to firstly have a faster absorption rate. It's going to have a higher plasma concentration and remain above the target concentration for a longer period of time, even if they have the same concentration or the same dose, because they're going to have the same average blood concentration, but just by changing the rate of absorption, you're getting a more maximum concentration above target for longer. It's a concept I didn't really understand when I learned it, so I thought I'd just put a slide on it so you can see how changing the rate of absorption influences concentration. Next slide, please. Plasma proteins. The main plasma protein is albumin, and it reduces the amount of free drug circulating in the plasma. Once the drug is bound to albumin, it's essentially inactive, and it doesn't really interact with body systems. Here's an example here. So 90% of the drug is bound and it's not having an effect, and this reduces the concentration of systemic circulation. It means the effect of the drug can occur over a longer period of time, and it has limited adverse effects. Only 10% is free. Here you can see that these drugs are displacing each other. So 20% are free, as opposed to just the normal 10% by themselves. When you put them together, 20% is free. Next slide, please. Therapeutic index, you just need to know that word. It's the ratio of a drug producing adverse effect to the drug producing desired effects. The higher the therapeutic index, the safer it is to administer. The higher the therapeutic index, basically the bigger this range is. So this is when it's the minimum effective concentration, so the concentration you need for the drug to essentially work, which has significant clinical physiological effects. And above this line, it's toxic. So you want a high ratio, high range, high index. A low index is quite dangerous to administer, and you need to monitor closely because the difference between just being effective and being toxic is quite small. Next slide, please. Elimination. So as drugs begin to circulate and to be metabolized, they begin to lose concentration. Particularly this example is referring to as you administer a drug, it's going to spread out throughout the whole body. And sometimes you want a drug to be localized to a particular area. Sometimes you can give adrenaline to constrict the systemic kind of diffusion of the drug, and it's going to stay in that one area. Inactivation or breakdown occurs through metabolism. We've talked about first pass metabolism, and then a drug can be excreted once metabolized and you get it out of your body. The kidneys excrete water-soluble drugs or water-soluble metabolites from lipophilic drugs. So these lipophilic drugs will undergo metabolisms to make metabolites, and then these are excreted. Lungs remove gases and volatile liquids through breathing, and the gut excrete drugs through bowel or feces. And also sweat, saliva, mucus, tears can all excrete trace concentration of drugs. This is low yield. These are more high yield, but it's all just a big picture conception. Yeah, I think that's it. Yeah, thanks so much. Are there any questions? I hope the zero order first order wasn't too confusing, but it is pretty confusing. Andrew's described it pretty well here.
Okay, if there's no questions, we might move on. But as always, if you have any questions, just feel free to ask us. You can DM us on Messenger, Facebook, anything. So if you're confused by anything, don't be afraid to ask. I bothered a lot of third years and I bothered a lot of second years when I was in first year with questions. But come to our houses. Well, David, I don't think they know where we live. I'd be concerned if they did. But moving on, healing and repair, let's go. So the pathology this week, not that important, just kind of know generally, just get the big idea. Like I haven't really seen it come up much at all. So I don't think it's that important unless some of the other members think it's a bit more important, but I think generally we can probably agree it's not too important. So just get a general idea of all of these concepts. So first thing is when your cells become injured, what happens to it? So you can have three outcomes. One is regeneration or resolution. So that's where you get regeneration of the original tissue. So for example, I don't know, if you got a cut or something, then it just like regenerates and it's back to normal. So it'll occur when the injury is sort of limited or short-term with little damage. And it happens in tissues capable of regenerating. So these tissues are termed labile. That means they can regenerate a lot, they can divide a lot, that kind of stuff. So that will be something like your epithelial cells, like your skin cells. Something that's not like this would be probably your heart. So if you get a heart attack and your cardiomyocytes die off, they're not actually able to regenerate. And then the next one is adaptation, which is basically where the cells that are normally there get replaced by a different type of tissue. And then the third type is just scarring, which is when the injury is substantial or the tissue isn't capable of regeneration, such as when we're talking about the heart. or following chronic inflammation. So instead, they'll be replaced by a lot of collagen and fibrous tissue, and it'll just become a scar. So if you had a heart attack, your heart muscles die, it'll become scarred instead. It won't regenerate. Next slide, please. So this is the normal wound healing process. So what happens when you get injured is, first of all, there's hemostasis, which is basically a blood clotting. There's vasoconstriction to stop the amount of blood sort of being lost. And then your platelets will aggregate and clump, and then you get all of that blood clotting process that you've learned about, I think. And then you get inflammation, which you would also know about, where you just basically get cells and fluid moving from the blood into the tissue. And then thirdly, you get cell proliferation. So this is sort of like when the repair starts. The extracellular matrix, there's synthesis of it. So you also get granulation tissue forms. What's granulation tissue? It's basically new connective tissue and microscopic blood vessels that are forming at the wound. And there's also angiogenesis, which is the formation of these bigger new blood vessels. So these blood vessels are important because they bring nutrients, they bring cells, etc., that are important for the wound healing process. Because, you know, if you didn't have any maybe immune cells, or if you didn't have any nutrients coming, then you might get an infection. Or if you just didn't have nutrients, obviously it just wouldn't regenerate. And then finally, you have reepithelialization, which is just the formation of a new layer of epithelial tissue. So that's your skin. And then you get maturation. So there'll be some remodeling. Some of the extracellular matrix that was made while you were healing will be replaced by the normal cells that should be there, because when you're just healing, sometimes you'll get fibrous or connective tissue that's sort of kind of like scaffolding. It's just there in the meanwhile, while everything else heals up. And then secondly, you get wound closure, which is basically your body will sort of like try to contract the edges of the wound together to bring the edges of the wound a bit closer. It sounds a bit odd, but that's what it does. Next slide, please. And this is just a diagram for you. So first of all, you can see hemostasis, you get a blood clot. Secondarily, you get inflammation, you have fibroblasts. They'll lay down some fibrin, you'll get scabbing, and then your macrophages will be here to, you know, if you have any bacteria here, there, they'll fight it. And then the third stage is proliferative. So you can see that extracellular matrix is being made. Basically, the body is just rebuilding. And then you get remodeling. So once it's all rebuilt, your normal cells will start getting put back there. If you had some like extracellular matrix that was just there in the meanwhile, they get replaced by your normal tissue. Next, please. So there's two types of healing of skin wounds. So first of all, you have something that's called first intention, and then you have something that's called second intention. So first intention would be something like if you had a surgical wound. So it's just a very clean cut. In that case, you can just bring the edges of the wound back together, and you can hold them in place using something like sutures. So the wound is easily closed and the dead space will be eliminated. Excuse me. Second intention healing is where there's a greater loss of tissue and the edges can't be brought back together. So in this case, you might have a bit more scarring, and this might be something that happens in deep lacerations, deep cuts, or extensive burning, or have abscesses forming, something like that. So there'll be a combination of regeneration and scarring instead. You have phagocytosis by your macrophages and other cells, which removes debris, and formation of granulation tissue, and then epithelial regeneration, which is similar. And hopefully this will become a bit clearer with the diagram that we have on the next slide. So on the left-hand side, you can see what is primary intention or first intention. So this is when you have a clean, narrow incision. You can see that it's kind of like a valley, I guess, in your skin, and basically you can just suture that shut, and then it will heal a lot more cleaner. Oh, thanks. Heal a lot more cleaner, and there'll be minimal scarring. But if you, as you can see on the right-hand side, if you have something that's a bit more deep, a bit more sort of a bigger injury, and it's broader based, then you can see that you can't just bring the edges closer. So then you sort of get that wound healing process that we were talking about before, where you get inflammation, you get hemostasis, and then you get granulation tissue. And eventually the tissue regenerates, but you might get a bit of scarring, and yeah, and you'll need some remodeling, but it won't be completely the same. Next, please. So just some examples, mucosal erosion. So this is in your stomach or GIT. Perhaps you have something like an ulcer. So if there's some erosion of just the top layer of epithelium, or there's just partial erosion, then it will be quite simple, and the viable epithelial cells next to the damaged area can just rapidly replicate, and it will just basically replace the epithelial cells. But if it goes a bit deeper through your stomach, through the full thickness of the mucosa, which is basically the wall of your GIT, then you will need secondary intention healing, where you have hemostasis, inflammation, granulation tissue, and regeneration of the mucosal epithelium. So basically the same as before. Basically, if it's a clean cut, first intention. If it's a bigger wound, then it'll be second intention. Next, please. And then just a bone fracture, you don't really need to know this either, but it's an example they give. So if you break your bone, you'll have hemostasis, it will stop the bleeding, and you'll have something called a hematoma, which you can see in the diagram, which is basically just like the platelet and fibrin plug. You'll have inflammation. This inflammation will help remove like bone fragments, stuff like that. And then there will be some organization, which is basically remodeling of the hematoma to form a cartilage callus, which is fibroblasts and osteoblasts. These osteoblasts will become the new bone, and you have some new blood vessels, and it's kind of like a scab for the bone, basically. And finally, once everything's grown back to the place, you get remodeling. As you can see in the third stage, it's sort of a bit big. And then in the last stage, it's just trying to remodel it back to a normal size bone. Not too important though. Next, please. And then we have apoptosis and necrosis, also quite a short section, not that important either. Just get the big ideas here as well. So apoptosis and necrosis. Apoptosis is where basically a cell commits suicide. It's controlled and it's regulated. So the cell might go into apoptosis if it's damaged and it decides, oh, it can't be repaired, and basically it'll, suicide. Or if the body decides the cell is no longer useful, then it might also undergo apoptosis. On the other hand, necrosis is accidental death of a group of cells. Sorry, I missed a word there. And it's usually due to pathological injury. And instead of a nice, clean sort of self-destruct, it will spew out all its contents, and you'll get a ton of inflammatory markers as a result. So we have a table here that just basically compares them to, but that's the main idea. One is controlled and the other one isn't, and necrosis is obviously a lot worse than apoptosis. So apoptosis can be physiological, like if the cell's no longer useful, but also pathological if the cell thinks that it sustained too much damage. Necrosis is always due to like pathological injury, something like frostbite, for example. Apoptosis will occur in single cells. Necrosis will occur in a group of cells. It's energy dependent for apoptosis, whereas necrosis is passive. Sort of the cells are too damaged to undergo apoptosis, and they will just sort of rot to death in that sense. And the cell processes of apoptosis, basically the cell shrinks, and then it will like fragment its nucleus, not too important. Necrosis, the cell will swell and sort of just erupt. And there won't be an inflammatory response for apoptosis. There will be, however, for necrosis, because of all of that inflammatory markers it's spewing out. And yeah, so that's basically the overview of apoptosis and necrosis. And there's different types of necrosis. So you'll probably go through this in a workshop, but some of them include coagulative, where the tissue coagulates. It's like a gel. It can be liquefactive, so it liquefies. It can be caseous, so it's cheese-like creamy material, yummy. You can also get fat instead. You can get fibrinoid, where fibrin is laid down. So all these different types, and you can see on the right, the brain is in the top left. It's just necrosed, and that will be liquefactive. because the brain is, or it just undergoes liquefactive necrosis. But once again, not too important, doesn't get mentioned much at all, just know this exists. And next slide, please. I think that might be all. Pathology is not very long this week, luckily, and not too important, so don't get too hung up on it. Pharmacokinetics probably more useful to spend time on. And if you have any questions, let us know.
Okay, yeah, so this week for HKS, we'll be going through refugees and asylum seekers. Right, these are the learning objectives that we'll focus on for this week. So the numbers and definitions. These are pretty important because there'll be these words will be used throughout the notes and the lectures. You just got to make sure you understand which one's which because they are relatively similar. So internally displaced is they fled from their homes but has not crossed international borders yet. So they're internally without a home. Asylum seekers are someone who has left their homes or home country due to fear of persecution, but has not yet been granted legal refugee status. Then refugees are people who have been forced to leave their country in order to escape war, persecution, or natural disaster, and has been recognized as a refugee by a foreign country. And Australia accepts around 18,750 refugees every year. And that's the difference. So as you can see in this graph, there's asylum seekers, and then there's the refugees, and then there's also internally displaced people. So there's a lot of those who are without homes, and not many that are actually considered refugees compared to the fact that there's a lot of people internally displaced. Also health issues faced by refugees. This is pretty important because this will, if you ever come across a scenario or a patient that was a refugee or is a refugee, you will need to understand that they will have very different environment that they've been growing up in, but also factors that are affecting their health issues. So pre-arrival factors. First of all, it's the fact that there might be different standards of healthcare system in the country of origin. And there's a high chance that it's not as good as Australia because they're either going through conflict or natural disaster, so catastrophic events. So they probably won't have a good healthcare system in the first place. Also experiences of the individual, so they probably might have things like PTSD or trauma or conflict, physical damage done to them as well. Also time in refugee camps or mandatory detention. You guys probably heard all of those bad stories about refugee camps and the mistreatment that occurs and how long some people stay in there for. That could definitely have detrimental impacts on these people. So you have to think about that. And as I said, poor access to healthcare on the way to the country of destination is also something you should think about. Now, after they are, basically granted to live in Australia, there's also other factors such as the fact that it's difficult to access healthcare in Australia, also problems with health screening, language barriers is pretty big. Also financially, they might not be, they might not have enough money to go to doctors every single time. Also lack of knowledge about healthcare system is also very bad, or a very big factor. Also, there is an ASID guideline, ask, and this is a slide from the lecture, and basically that's what you kind of ask for the people, and you can definitely get an interpreter for those who can't speak English really well or want to get someone that will have medical knowledge that can speak to their language about medical stuff. Because even though, for example, you might be good enough to talk to your parents if they speak a different language, you might not have the medical terminology to actually explain to them. So you might need to get an interpreter, even though you might be good with just everyday English. So that's what basically it is. But there are a lot of problems with interpreters. Some medical terms might be difficult, and also accuracy is hard. And as I said, family members often soften or delete difficult news. So if you use a family member, that might be a problem. Also, lack of confidentiality. You're bringing another person in. And also guilt of a misdiagnosis if missed through poor interpretation. So that's that. Then there's screen. So that's just screening in general. you learn about the differences between screening and like other things, but basically all refugees should be screened for mental health and a lot of other different things like Hep B, HIV, and other things, depending especially if they come from a certain region that we know that there's a high incidence of Hep B or things like that, like malaria, Hep C. There's also kindness. You gotta always make sure as a doctor you're not being angry, which sounds very obvious, but sometimes you might, because of the fact that you might not be able to talk to them, or they might have different cultures, you might not be able to understand them from the start. Just gotta make sure you always have a holistic approach and accept that there are cultural differences and mitigate the risk of re-traumatization, because these people probably have been traumatized for their journey to Australia. And that's it for HKS. So it's relatively, in a way, if you've been kind of up to date with news, you would have seen a lot of these news. So it's nothing really new, but it's very important, especially because in Australia, we accept a lot of refugees, and you will come across patients who were refugees or are refugees. So now we'll move on to MOM, I think that's medicine of mind. And this week we have stress and illness and becoming ill. So for stress, so define the concept of stress and apply complementary models to stress to clinical examples. So stress, there's basically 3 ways that the faculty wants you to know. So stress can either be or be regarded as an external stimulus, or a reaction between event and an individual, or an internal physiological reaction. So as an external stimulus, stress is regarded as an outside force that has basically an effect on our body or mind, and the effects can be physical or psychological, and they aren't always bad. So stress, even though we normally use it as a bad term, can be positive in medical field, but normally we regard it as negative, but you definitely can have positive stress. And if you're going to regard stress as a reaction between event and individual, this means that it considers not only the nature of the event, but the nature of the person who experiences it. And also, if you consider it as an internal physiological reaction, it's basically how the body responds after the stress is perceived by a central nervous system. And then you have a cascade or basically complex psychological or physiological events, and that is how we handle stress. So for example, elevated levels of cortisol. So what happens when you are stressed? So you'll learn about this in, I think, physiology, but I'm not 100% sure. Basically in other subjects in way more medical detail or scientific detail, but basically the general gist is that once you're stressed, the sympathetic nervous system of the autonomic nervous system is activated. That's the fight-flight response. And these responses are basically created for survival. So more blood to the legs, so David can run away from a tiger. But then what happens afterwards, right after the stress is gone or your threat is going away? Then the parasympathetic nervous system of the autonomic nervous system gets things back to normal or returns to homeostasis, and basically does the opposite of the sympathetic nervous system. So less blood to muscles in the leg because there's no more tiger, right? So there's different effects that stress does to the body. Short term is okay, and sometimes without stress, it's actually bad in a way. You might sometimes need some relatively good stress for you to continue to do certain things, but obviously in long term, it's not good because that most likely means that your sympathetic nervous system is continuously being active and it's not returning to homeostasis, which is bad for your body. And there's also different types of stress. There's 2 main, acute and a chronic. And as you can just infer from the name, acute is something that is short-term, chronic is long-term and ongoing. Yeah, so that's relatively straightforward. And then there's coping. So coping means what a person does to reduce the impact of a perceived stressor. So something really important here is it's what a person does to reduce the impact of a perceived stressor. So just because you think it's a stress does not mean that someone else thinks it's a stress. So it's also a psychological thing. But how do we cope with this? Well, basically, it helps us decrease negative emotions And also we alter the stressor directly. So if it's a relationship breakup, we study for exam, things like that. Classification of coping strategies. So there's two, there's adaptive. We try to fix the problem and basically adapt to the fact that we need to do something about this. And then there's maladaptive, which is basically avoiding or just not helping with ourselves. So drinking alcohol, violence, denial. Coping resources can also be internal, so self-esteem, persistent self-efficacy, or external, family, friends, teachers, or healthcare workers, whatever. There's also coping styles. It's two different, there's problem focus and emotion focus. Problem focus is basically focusing on the problem. So you plan, you confront, you seek for the information. Emotional support or emotions focus is you support, you try to find support, you venting, you praying, reframing. Attentional is vigilant monitoring, and avoidant is distraction, daydreaming, substance misuse, and kind of maladaptive. And this is just a thing that you will need to know, Lazarus and Folkman. It just talks about how social support has illness and direct links to illness and indirect links and things like that, and how it kind of all links together. And then also primary, secondary appraisal. If you guys do psychology 3-4, you'd have come across it. I don't think we actually necessarily went into detail, so I won't comment on that. But it's a good diagram that kind of explains it. Yeah, now we want to go into becoming ill. So what happens when you're about to become ill or you're getting sick? So really important to know the difference between sign and symptoms. So it can be confusing at the start, but basically signs and objective change in the body. Sorry. For example, stiff legs. And then a symptom is an interpretation of a sign as an aversive marker of disease. So we have to interpret the sign and regard it as a marker of disease. That's what a symptom is, right? So if a sign is stiff legs, then a symptom is stiff legs due to Huntington's disease. So symptom perception is a process of interpreting the signs as a symptom. And there's some factors that affect this. So there's gendered illnesses, so certain sickness or illnesses are more likely to affect certain genders. So that's a factor. Also a negative emotional state. So it's kind of projected onto the situation and it kind of focuses the attention towards the threat. So we could have a thing like that. Also selective attention, because there's a lot of things, signs that kind of occur in our body and our attention is in a way limited. We need to sometimes just, our body decides to focus on certain signs over other signs. So that's also a thing. Also, there's situational variables, so external distractions. So this is a diagram that they will have in a lecture, basically explaining how it works. There's like a disease, and then somatic information, and then there's all these different factors that could affect the sign and how we decide about the sign. And then there's also sets, which we'll go into a bit later. And then there's the symptom, and then there's a health complaint. And these red ones are also what you do as a doctor, and detect and then interpret the symptom and then attribute. So symptom interpretation. Symptoms are matched with labels or illnesses. And there's this thing called symmetry rule. So the more symmetry, so there's actually, I'm not sure writing right there, but basically it's like a rule where if there's more symmetry between the symptoms that we're matching with the labels, that means there's better behavioral outcome. I'm not quite sure about that. I should fix that, but yep. And also lack of symptoms or consequences lead to poor adherence or like drugs, like things like that. And factors influencing this is gender, cognitive development, cultural models of illnesses, individual differences, and familiarity with illness from social learning and public information. And I think this was the second last slide. This is a common sense model. It's a framework to assess the threats and understand the impact of this and the emotions that motivate the protective behavior of us. And basically, this is just how it is. You should probably go through the slides, look at this diagram and try to understand what we're doing. It's relatively straightforward. And basically, the last part is attribution. So if you look here, also one thing really important here is to understand illness representation. So these are the 5 things. Identify, so label the symptoms, the consequences, cause, control, and timeline. So we have to ask this and find out what the symptoms mean for those. Okay, attribution. This is a process of inferring the causes, a meaning of our mental and physical states and behaviors, including bodily symptoms and illnesses. So there's two broad types, external, or we call it situational. So this is because the behavior is due to a situation. And then there's internal or dispositional, which means behavior reflects personal traits or abilities. Types of attribution, there's three different types, basically. Stable against unstable. And this is basically stable is like, I'll never be able to exercise regularly. Whereas unstable is, I've never been able to exercise lately as it has been too hot. So that's kind of like an example. Global diabetes affects all aspects of my life, whereas specific is diabetes prevents me from eating certain foods. So those are, again, two different types. And then there's controllable, which is I can avoid getting sick again by exercising and sticking my medication. So then you can control what you can do. Whereas uncontrollable is I just know things will conspire against me and I won't be eating well or taking my tablets regularly, or we call that locus of control. So those are different types. From memory, these weren't that important and they're relatively straightforward in terms of the names as well. So let's have a read through that. And I think, oh, and then there's errors, my bad. So there are some areas of attribution that we do naturally because we're humans. And there's three different types. Fundamental attribution error, that's when we decide and underestimate the external factors and overestimate the internal factors, basically, the impacts of them. And then there's an actor-observer bias, which is when we basically attribute our own behavior to an external cause, especially if negative. So if you fail an exam, it's because of a teacher that didn't teach you, or not because you didn't study, things like that. And then there's self-serving bias. So there's three different types for this as well. So there's the self-enhancing bias. So that's when you attribute success to your own personal factors. And then there's self-protecting bias, which is you attribute your failures to situational factors. And then there's self-handicapping, which is foreshadowing the future. Yep, and that's it. I think there's one slide after.
Yep, so I'll be taking you guys through your last immune system lecture. So today we're looking at adaptive immunity roles and functions. Next slide, please. Yeah, so pretty much you would have had 2 immune system lectures already, I believe. Correct me if I'm wrong. You've basically gone over adaptive immunity already. So this lecture is really to provide a bit of a refresher, provide some further details on specific parts of the adaptive immune system, and also look at how the adaptive immune system sort of functions in the context of some human conditions. So for example, a viral infection, and also in the case of cancer. Yeah, so a bit of a recap. So basically when you are infected with a pathogen, what happens is that your antigen presenting cells, so your macrophages, your dendritic cells, they will take up pathogens, process and present them in their surface MHC class 1 molecules. So that's if they're intracellular pathogens, for example, viruses. So remember, MHC class 1 shows sort of what's inside of the cell, and your MHC class 2 molecules show sort of extracellular pathogens. So our APCs, they now move to the lymph node and find T cells with matching receptors, and they get activated. So we activate 2 sorts of T cells. So the MHC class 2 activates our T helper cells, and our MHC class 1 activates our T cytotoxic cells, also known as CD4 and CD8. So a trick to remember this is the rule of 8. So for example, for CD4, they're going to be paired up with MHC class 2 because 2 times 4 gives you 8. Similarly, our CD8 will be paired up with MHC class 1. So 1 times 8 gives you 8 as well. So that's a little trick to remember which is which. So what our T helper cells do when they're activated, that they go on to activate B cells to produce antibodies against our extracellular pathogens. Now, our T cytotoxic cells, what they do is they then go on to kill the body's own cells, which have been infected by an intracellular pathogen. So, for example, a virus, by finding a matching pathogen peptide on MHC class 1. So the antibodies won't really work on intracellular pathogens because the antibodies won't be able to attach onto them if they're sort of hiding inside the cell covered by the plasma membrane. Next slide, please. Yep, so that was all pretty much revision. So we'll go and look at the phases of the adaptive immune response now. So we have 5 main phases, basically. We start off with our antigen presenting cell, our APC, activating our B cells and also our T cells. And what happens after that is we have a massive expansion in immune cell numbers. So you can see this blue curve going up. We have clonal expansion. We also have differentiation. So our B cells will become our plasma cells or our memory B cells. Now T cells also differentiate into our cytotoxic and also our helper T cells and also our memory T cells. And as we go through this activation phase, the cells start to kill off all the pathogens with the help of the antibodies. And so when that happens, the number of cells sort of starts to decrease. And as we eliminate the antigens and the pathogens, these extra immune cells will undergo apoptosis. And at the very end, we are left with just our memory T and B cells. Great. So adaptive immunity memory. So this is really important because it shows us why vaccines work, basically. So through memory T and B cells, the body is able to remember past infections. The important thing here is, however, is that if there is an infection again of the same pathogen, the adaptive immune response is both quicker and stronger. So if we look at this diagram on the bottom right corner, you can see at the very start, on the x-axis, we have time. On the y-axis, we have our antibody concentration. So basically how strong our immune response is. So when we're first exposed to an antigen, it takes about 10 days for our IgM antibodies to be produced, followed by our IgG. So you can see there's about a time delay of 10 days. And after that subsides, we have our memory T and B cells. So when we do get a second infection, shown by the secondary antigen exposure, you can see that the immune response is now much quicker. So previously, our antibodies didn't start rising until the 10-day mark. Now they're rising at around the 4 or 5 day mark. And not only that, if you look at IgG, right, it spikes up significantly as well to levels multiple times that of your primary exposure. So this is basically why we vaccinate. So we stimulate an immune response using a weakened version of the pathogen. When we are infected by the real pathogen, our immune system will already have memory and deal with it much more effectively. That's because our secondary immune response is both much quicker and stronger. Yeah. And also, to provide some more details on how antibodies actually work. So you can think of them as having 3 main functions. So they help neutralize microbes and toxins. And secondly, they also help in the process of opsonization. So basically, when our antibody is attached to a pathogen, so for example, a bacteria molecule, it allows our phagocytes, our macrophages, to phagocytose them much more efficiently. That's because the phagocytes, they have a greater affinity for the antibodies. So that's opsonization, basically the process which increases the efficiency of phagocytosis. And antibodies also serve an important process in activating our complement proteins. So not sure if you guys have gone into complement in much detail. If not, they're basically these inactivated proteins that float around in your bloodstream. But what antibodies do is they activate them. And so these proteins, they can form attack complexes, which sort of punch holes in microbes. They also help in further opsonization, also mediate inflammation. Yep. Next slide, please. Yep. And so we'll look at the immune system in the context of a viral infection now. So this is quite high yield. So it's good to sort of take some time and go through each step and sort of like write them down and understand them. So if we are infected with a virus, our APCs will, so there's sort of two pathways that happen here. Our APCs can be infected by the virus itself. And because that is an intracellular pathogen, it will then be presented on MHC1 molecules. Another way is that the APCs may not get infected by the viruses, but instead capture them. And in that case, they'll be presented on the MHC2 molecules. So over here, you can see that if we take up sort of viral debris, if we sort of capture it, it's going to end up on our MHC2. But if our immune cell gets infected itself, it will also show up on MHC1. So our antigen-presenting cell will then move to the lymph node to find matching T cells. So in a viral infection, both T helper cells and T cytotoxic cells will be activated. So the T helper cells will activate B cells to produce antibodies. So in this case, what role do antibodies have against the virus? Well, it's not going to be very useful if the virus is inside a cell, but it's going to be very useful if the viruses are floating around freely in the blood plasma. So for example, if the virus bursts out of the cell, then these antibodies will be able to effectively attach onto them. Finally, those cytotoxic cells will kill our own cells, which have been infected by the virus through recognizing that MHC class 1 and peptide combination. Next slide, please. Yep, and finally looking at our immune system in response to tumors. So it turns out that our body has a very similar process in dealing with cancerous cells from our own body. So yeah, basically our antigen-presenting cells will detect and phagocytose tumor cell peptides. So cancerous cells, they have different characteristics to our normal cells. So they will have different proteins, and our APCs will be able to recognize that difference. So present them on their surface MHC class 1 molecules. Once again, it's the same process. Our APCs will move to our lymph node to find the matching T cells. When dealing with tumors, it's less antibodies and more our cytotoxic T cells that are activated. And these cytotoxic T cells will then go on to sort of find matching cancerous cells and kill them by recognizing the MHC class 1 and peptide combination. Yeah, so next slide. Yeah, so first time that I learned immunology, it was quite confusing, sort of different bits of pieces of information. I recommend sort of checking out this summary from online and sort of working through it. And there's one correction. In the summary, it says that APCs have MHC class 1 and class 2. And it says that other cells only have MHC class 2, but in fact, it's only MHC class 1. Yeah, so I highly recommend you guys also check out this summary if you're still a bit confused about the whole immune process from start to finish. Yep, otherwise that's all from me today. Yeah, no problem.